And without further ado, I'm just going to go ahead and introduce Maureen O'Hara, be the first speaker. She got her basically educated as a biochemist in England and then got her Ph.D. at Union Graduate School, and then worked for a number of years with Carl Rogers, did a lot of the work on peace with that Rogers was doing, a lot of training. She's taught psychology of women at San Diego State University, done clinical training at California School for Professional Psychology. She's currently the president of the Association of Humanistic Psychology, and she's co-founder of a group here in the San Diego area called Women for Change. And finally, she said to mention that she lives in relationship with a husband, a son, and a dog. And with that, I will introduce Maureen O'Hara.
I'm probably going to try to stay pretty close to the text, primarily because I want to get some very broad strokes talked about in a very short period of time. And I just want to say that two reasons why I'm really glad to be here. One is that I always like to be around people who are intellectually engaged with the kinds of puzzles that SEPI seems to have set as its puzzle. The other is to be on the same panel as Ellen McGrath, who is one of my heroes, and I'm just utterly thrilled to be here on this panel. So let me go for it. At last count, there was close to 400 different name brand therapies that are competing for the client's dollars and for the students' training dollars. Their inventors, whether of the major established schools or the treatments of the month, all claim that their approaches are valid and are true in some objective way. On the basis of this, a whole profession with elaborate legitimizing structures and procedures has evolved that gives a sense of solidity to the whole field. At the same time, though, as these legitimizing structures are being built and strengthened and rigidified, members of marginal groups like women and people of different ethnic cultures are busily criticizing and deconstructing the whole edifice by advancing the postmodernist arguments that all these theories and practices are based in a worldview that reflects the habits of mind, realities, and values of the people who are inventing them. These post-structuralist critics suggest that all totalizing discourses, in ordinary language, grand theories of everything, are suspect, that knower and known are inseparably linked, and that in advanced technological societies like ours, psychology has created a theory and practice in its own image. And if that wasn't confusing enough, there's a whole conversation going on that suggests that the image enshrined at the center of the mental health community as the ideal of mental health is actually deeply sick, and the treatments based upon it ultimately make people worse, not better. In some ways, whether we're aware of it or not, we've all become postmodernists. When we put together studies from social learning theory, cognitive science, neurological studies, perception, depth psychology, sociology, anthropology, and any number of critical studies, we come to the conclusion that the inner psychological world of human beings, our consciousness or subjectivity, is a creative product. The I that each of us knows is produced through non-stop dialogical engagements with the world into which it's born and it lives. Inner sensations and perceptions of external events are interpreted, symbols, narratives, and conceptual schemas generated, against which new experiences are constantly being referred. This produces, with various degrees of permanence or fluidity, our subjective inner symbolic map for the self in the world. If this constructivist view is correct, then we should expect that participation in different sociocultural landscapes would produce different kinds of inner selves, and this is exactly what we do find. In Western cultures, especially here in the United States, people seem to experience themselves with a clear, lived sense of the I, which they refer to as myself, and they expect it to be the same I throughout their lives. This self is clearly distinguishable from other selves. When changes occur in this sense, that's what we mean by growth or therapy or healing or development, we in the West prefer this to be gradual. Radical transformations or discontinuities are expected to be accompanied by anxiety. Not to know clearly who one is, to lose the sense of coherence and continuity, is felt as a loss of self. In Western culture, this kind of disintegration and disorder within an individual has become equated with mental illness, even madness. Freedom and the recognition of the integrity of that self by others is also highly prized. In fact, as many authors have described, the autonomous, clearly bounded, self-assertive, self-responsible individual who acts consistently and coherently is the definition, the sine qua non of psychological health for both males and females. Not in all cultures, though, and not in all communities, and not in all historical eras, does this ideal of personhood, does the ideal of personhood imply this strong sense of a distinct, individuated, and stable self. In fact, anthropologist Clifford Geertz has pointed out that this is rather rare amongst the world's cultures and isn't at all valued. In fact, many cultures go to considerable lengths to discourage such a psychological pattern for adults. In studies comparing the self-concepts of late 20th century North Americans with Asian Indians, Schwader and Born, for example, found that in contrast to the American ideal, in India, the person is seen and sees him or herself as regulated by strict and complex rules of relation and interdependence that are context-specific and are pluralistic. A person is judged in terms of social roles and situations. The ideal person is not one with a strong sense of individual identity, but one who participates well within their social contexts. Americans, when asked to describe some particular person, such as their best friend or themselves, give abstract descriptions of identity, such as, she's moody, or he's insecure. Indians in Schwader's study, on the other hand, give contextual descriptions, such as, she suffered a great deal when the village was destroyed, or he remembers his mother on holidays. In other words, Indians give phenomenological descriptions of how one would expect the person to behave in specific, concrete, relational circumstances. They had no particular interest in the abstract, definitional descriptions favored by the Westerners. Schwader and Born compared many different cultures and developed a polarity with our culture, which they called an egocentric culture, at one end of the polarity, and Asian cultures and other indigenous peoples' cultures on the other end of the polarity, sociocentric. Now, the I, which is conceptualized at the center of our educational system, our system of laws and our social conventions, and more importantly for this discussion, at the center of our psychology, and its ideal self, its ideals of health and treatment, and its sense of illness and pathology, are based in a very Western and very egocentric view of the person. So much the standard within the mental health community that frequent observations that females and non-dominant males or ethnic groups often fell outside this description did not until recently result in any challenge to the picture. Rather, it resulted in the discrepancies being attributed to failures within the deviants themselves, who were consequently considered to be less developed and less psychologically healthy. In the time-honored tradition of blaming the victim, this conclusion was then used to justify traditional patterns of economic and political discrimination and ultimately abuse. In recent years, this bias has been subjected to increasing criticism. Realizing how much of the research upon which maps of the human psyche were drawn reflected the theoretical schemas of the minds of privileged elites, or if empirical were based on studies of white male college students, feminists and people of color have begun to accumulate alternative views of the psyche drawn by direct investigation of and by diverse peoples. The work of many feminist scholars, including Belenky et al., Jean Baker Miller and the Stone Center Group, Harriet Lerner, Sarah Ruddick, Carol Gilligan and her co-workers, and many others seem to show that women live their lives in their connections and relationships and evaluate their well-being in contextual and concrete terms. In other words, even in a culture like ours, women appear to be more sociocentric. Psychological well-being is not an individualistic affair, as women concern themselves not only with how they themselves are doing, but also how their relationships are doing, and how those they belong to, love, and care for are doing. Self-concept is also contextual and determined moment by moment and over time by how she's doing in the context in which she operates. As more attention is given to these different developmental patterns, it seems increasingly clear that the variations in self-patterns are due to more than just gender. Bell Hooks, Audre Lorde, James Baldwin, Gloria Anzaldúa, Aliva Espin, and many others have demonstrated, along with many social critics, that other factors, including race and class and position, are all implicated in this analysis. Brazilian educator Paulo Freire has suggested that living life as a subordinate, either to a social order or to another individual, results by virtue of necessity in the development of a greater dependence upon and a greater sensitivity and vulnerability to the workings and dynamics of relationships, of groups, and of communities. There has been some trepidation amongst feminists that suggesting that women have distinct ways of knowing or different voices, are more relational and family-oriented, leads us back into the sex-segregated world that women have been so damaged by. Other women, though, feel empowered by the notion that instead of continuing to have women's experience disappear, subsumed as some kind of inferior variant of the generic human, women's distinct subjectivity is finally achieving epistemic validity. I think it's impossible for us in psychology to overestimate the importance of this discussion. It's one that's continuing to push us further and further into the epistemological debates that are raging in disciplines from anthropology to literary criticism to political science as to the nature of reality itself. In that discussion, the realization is gaining ground that we don't all live in the same perceptual universe. We don't all have the same kinds of selves. We don't all care about, value, or believe in the same things, and that in a multi-hued, multi-voiced, and multi-context world, any kind of grand integrative theory that tries to abstract a person out of their particular context is bound to miss the mark. And when that theory is based and reflects the particular interests and worldview of dominating elites, such totalizing discourses have the power to, and historically have, led to patterns of social injustice and interpersonal abuse. And beyond that, the desire for such grand integrative theory itself must be seen as both effect and cause of a great deal of the psychological pain that we see around us. At the risk of jumping to a premature conclusion to this discussion, I would like to propose that what's emerging is the need to develop in our society, in our science, and in our psychology, and in our lives, nothing short of new ways of understanding the human condition, new perceptual patterns, and new ways of approaching the issue of mental distress at its most fundamental. If we're to live well in a pluralistic world that we now all inhabit, we will need a kind of flexible vision that combines features of both contextual sociocentric vision and the abstract egocentric views that we're familiar with. In any case, what emerges clearly from all these critiques is that it's surely no longer feasible for psychologists to consider questions of psychological development, functioning, and psychotherapeutic treatment of anyone without considering the specific, concrete situations and contexts in which they participate, and examining the basic worldviews at the center of both the client's and the therapist's psychological landscapes. What we need and I suggest we need urgently, is a relational and contextual psychology that is capable of seeing individuals at one and the same time as unique, embodied, creative centers of consciousness and as participants in larger groups and larger realities, subject to pressures and forces and recipients of resources and possibilities which originate beyond the realm of the individual. We need a psychology that can see psychological life in both individual and relational terms. One attempt to create such a relational approach is the self-in-relation approach that has been developed by Jean Baker Miller and her colleagues at the Wellesley College Stone Center. There is not time to elaborate the specific details of their work, but I recommend you take a look at it. Not as therapy number 401, but as representing a whole new paradigm shift in how we think about basic human motivations, the etiology of mental illness, and how we think about treatment and prevention. Self-in-relation theory is one attempt at a sociocentric psychotherapy, one that sees human development in relational terms and looks to relational processes to facilitate growth and alleviate suffering. Like postmodern theorists Christopher Lasch, Robert Bellah, Daniel Yanklevich, Kenneth Gergen, Robert J. Lifton, Robert Romanishin, Jeffrey Satinover, and David Michael Levin, Stone Center theorists, central among them Jean Baker Miller, Judith Jordan, Janet Surrey, Alexandra Kaplan, and Irene Stiver, locate the origin of a great deal of our present epidemic of mental illness, especially of women, in the sense of isolation, disconnection, insignificance, and alienation that is the inevitable psychological outcome of life in our exaggeratedly egocentric culture. At first, Stone Center attention was focused exclusively on women's development. More recently, Stephen Bergman has begun to expand the analysis to include an analysis of men's realities in relational terms. In this setting, though, I'll focus on what they say about women. As I already indicated, Stone Center theory has at its center a sociocentric view of women's growth and development. The corollary of this is that in a world that favors egocentric individualism, such developmental patterns are not valued and are actually stigmatized, rebuffed, or pathologized. Child-rearing practices, educational practices, and institutional arrangements neither respect nor respond to these relational priorities. Instead of regarding the basic human motivation as individuation, self-actualization, and self-gratification, Stone Center theorists regard the fundamental human longing to be connection with others. Relationships are seen as valuable in and of themselves, rather than as sources of gratification for the individuals. Psychological pain is also seen in relational terms. Rather than emphasizing clear diagnostic categories that separate one person off from another, the focus shifts to examination of the violations, breakdowns in significant relationships, and identification of difficulties encountered in one's abilities to make and maintain good connections. Categories of difficulties, in egocentric language symptoms, are seen contextually and situationally, referring to concrete patterns of violation and disconnection. The focus of assessment and diagnosis moves away from the isolated individual to the ways that the people are participating in their relationships. This might include analysis of relational trauma, disappointment, abuse, or oppression on the micro scale of the family or on the macro scale of women's places in society. Analyses of the ways external images of women impact inner psychological well-being extends the old radical therapy adage that the personal is political to include the equally important social constructivist recognition of the fact that the political also becomes personal. When relationships fail, whether they're between parent and child, lover and lover, or individual and the society, we all suffer injury. The commonest response to such disconnection is to feel unworthy, unlovable, and to feel a heightened sense of vulnerability. We call this experience shame. Shame is frequently at the bottom of a whole range of psychological problems: addictions, eating disorders, depression, post-abuse disorders, anxiety, and personality disorders. In relational theory, shame becomes reframed. In place of the individualistic interpretation of shame as the result of narcissistic injury to one's individual sense of self, it becomes seen as the emotional reaction to violations of significant connections. It's not the loss of the connection as a source of narcissistic gratification that debilitates, but the loss of the relationship itself, and the feeling that one has lost one's rights and abilities to connect at all. These feelings lead to the conclusion that one's locked out of the human race, and frequently leads to a sense of alienation, hopelessness, and meaninglessness. This in turn may result in withdrawing even further, moving away from the means of making things better, locking one in to a spiral of shame. In his brilliant work on what he terms cultural epidemiology, David Michael Levin, following Michel Foucault, has suggested that this dynamic, generated culturally and involving the whole society, is at bottom the result of the fundamental objectivist separation of the knower from the known that followed the scientific revolution and the triumph of Cartesian dualism. He suggests that the epidemic levels of depression, narcissism, and schizophrenia are a result of dehumanizing patterns of life, including racial and gender exploitation and violent abuse, that follow inevitably from the breakdowns in our sense of connection, participation, and belonging. Robert Bellah and others also suggest that the social disintegration, the breakdown in community, and the rise of violence, drug abuse, and other forms of antisocial behavior are also sequelae of our individualistic ways of life. Disconnection, whether from the family or at the hands of a prejudiced society, creates shame. Shame creates psychological pain. Psychological pain creates either compensatory self-aggrandizement or self-defeating dependency. These compensations lead to more alienation and isolation, leading to more shame. These feelings of isolation and meaningless become overwhelming and ultimately lead to dissociation, antisocial gratifications, drug abuse, alcohol abuse, sexual exploitation, and even to violence and suicide. What I'm saying is, these conditions have been culturally generated. Self-in-relation theory proposes that if you wish to restore a person's sense of connection, you cannot do it through procedures based in the very assumptions that caused the disconnections in the first place. In other words, psychotherapeutic approaches and practices based in the same worldview that has led to our disconnections is unlikely to serve as an adequate basis for addressing pain. If we wish to heal the wounds of our disconnection, we must shift the focus of therapeutic attention to relational issues. There is not time here to deal with the details of how this plays out in different settings and with different psychological conditions, but let me give you a few examples of how this relational emphasis changes therapy. Firstly, there's a shift from exclusive focus on either biological or intrapsychic life to more holistic attention to the interactions of biosocial and cultural levels of existence. In particular, it moves focus towards exploration of the workings of relationships, especially the relationships with family and community, and with the therapist herself. Therapeutic attention is given to the development of relational competencies. Secondly, emphasis is placed on mutual responsibility for the therapeutic relationship, which is seen as a significant connection for both the therapist and the client in its own right. Relationships between clients and therapists are not generic and interchangeable, like the relationship between mechanic and machine. Instead, they're concrete, unique, and particular. They're specific relationships between specific people. Intimacy, the need for connection and for deep emotional involvement with the therapist, is not regarded as regressive, manipulative, or codependent, but as the healthy expression of the lifeblood of successful human life. In traditional therapies, love for the client for the therapist, or vice versa, are labeled transference or countertransference and interpreted as having to do with regressive impulses left over from unresolved issues with the family of origin. In relational therapy, such feelings are seen as legitimate attempts at connection and as valid human yearnings to be close. Even though the relationship is governed by ethical considerations designed to protect the client from exploitation of these yearnings by the therapist, the yearnings themselves can nonetheless be honored as healthy relational impulses. The focus of attention shifts to trying to help the client become more successful in all their relational life, not on becoming individuated and self-sufficient. One of the far-reaching consequences of relational thinking is that it throws into question many of the impersonal and alienating institutional practices that increasingly come to characterize the PPOs, the HMOs, and other large-scale mental health delivery systems. If we're right in our relational assumptions, then contacts with many, if not all, the large bureaucratic mental health institutions are as likely to be injuring those seeking help as they are to be healing. This liability falls disproportionately upon the poor without financial resources to go for their individual therapy with their own therapist. For example, the therapeutic journey usually involves re-experiencing painful experiences from the past. If patients are encouraged to re-experience painful and shameful memories within a system where they're treated like a diagnostic category or an object, then far from being healing, such remembrances may actually be recapitulations of the injurious situations themselves. When such feelings can be re-experienced within a significant relationship with a trusted therapist, then the client learns a different message. The message is, human pain is bearable if we're in this together. This view of the primacy of the relationship leads to a new set of metaphors, and more importantly, to a new metaphor for the self. It encourages and affirms a sociocentric self-concept, and it fits better with the way women already are. In traditional therapies, for example, you often hear people speaking of their real self or their inner child as if referring to some precious reality that must be kept hidden and out of connection. If it's to be safe, it leads to images and fantasies that the real self is somehow safer if it's alone. A great deal of the codependency and recovery literature reads like this. A relational sense of self sees vulnerability in a relationship as an opportunity for relational growth. If I'm feeling vulnerable, what do I need to ask from you so that I can feel safe and feel okay? It's important to point out attention is given to developing clarity about what one wants and what one needs and what one has to offer to relationships. This gain in clarity is often referred to as gaining a voice, telling one's truth, or becoming authentic. It's important to point out that voice is a relational metaphor. It implies both a speaker and a listener. It implies connection. I don't fully have a voice unless I can be heard the way I want to be heard. That means I must focus on the needs of the listener as well as my own. Authentic dialogue requires the involvement and participation of more than one person. For authentic dialogue to occur, the relationship also needs to be mutual. It needs to have a high level of trust, and power differentials need to be equalized. Both therapist and client must feel that what they say has authority for the other, not in some kind of official or power over way, but because it comes from the heart, and it comes with the feelings and the needs of the others in mind. There's nothing more stifling of true dialogue than the fact that the one party has the power to label and to control the life and liberty of the other. A relational view in no way negates autonomy. We're not suggesting some slavish martyrdom to one's connections. Autonomy becomes reframed, however, seen now as the ability to take the initiative within a relationship, the ability to respond authentically and spontaneously, and the ability to act intentionally and create change. Rather than see autonomy egocentrically as meaning one is free to act as one wills and let the other people deal with the consequences, relational sense of autonomy stresses freedom and responsibility, acting in ways that, although creative and potent, take into account the effect of one's actions on the people with whom one's in relationship. The ultimate goal of relational therapy is not the achievement of some conflict-free state, or in egocentric language, the resolution of all one's issues, but rather the development of flexibility in how one operates within conflicts, learning how to move in and through the conflicts in ways that neither necessitate fragmentation or withdrawal, or annihilation of the other. The most important ingredient in relational therapy, then, is empathy. Empathy is the relational skill par excellence. Not just the therapist's empathy for the client, but the client's empathy for the therapist and for themselves. In empathy, we move closer to each other and our common humanity. With self-empathy, we see the ways in which we're unique, but also the ways in which we belong to the human family. Ironically, some of our traditional therapeutic strategies, instead of being empathic, are themselves shaming. A client I saw recently, in a moment of intense panic, called a local psychiatric hospital. On the telephone, she asked to speak to a specific psychologist whom she knew. The psychologist on duty suggested that hospital policy was not to permit patients to request specific therapists, because that decision would be made on the basis of what the staff felt she needed. Her attempts to connect with someone she already knew were interpreted as controlling, and she was firmly put in her place. She fortunately knew enough not to admit herself. She did, however, suffer an intense shame attack. That's what brought it to me. When a person is shamed, they suspect their own sense of reality. The shamer's reality becomes real, and the shamed's reality is suspect. Again, knowing what is real is a relational issue. I learned to know reality in dialogue with others. This kind of therapy is on the one hand very simple, and on the other hand very difficult. If the relationships are seen as concrete and specific, then there can be few, if any, abstract generalizations about how much and in what way we should connect. We must be in each relationship uniquely. When client and therapist meet, at least two phenomenological universes come together. At the moment of the meeting, the whole psychological history and future, real and imagined, meets its opposite number. Once met, the two form a new relational whole with vast potentials for new levels of wisdom and understanding. Finally, it seems clear that a relational therapy in a pluralistic postmodern world will need to allow for a good deal of improvisation. Each therapy is unique. The techniques and topics we get into will come out of that particular relationship rather than some standard steps or practice. We will have to let the therapeutic process remain unformed, capable of uncertainty, and open to innovation and surprise. In particular, it seems that there can be no integrated one-size-fits-all. We must follow the client, not the theory or the insurance company. We must risk being changed in the relationship. If, like the ideal modernist, we get our sense of professional security from a sense of theoretical unity, knowing the right answers, making the correct diagnosis, knowing the correct protocols, we may find such fuzzy approaches very unsettling. We can be sure that our malpractice insurers may become pretty nervous. But as we enter further into the new paradigms of the postmodern world, we're coming to regard reality itself as fuzzy and uncertain. And the further we push for certainty, the fuzzier it seems to become. It turns out that in such a world, relationships and connections become vital sources of stability and security. As my 5-year-old nephew once said when we were in a thunderstorm together, when it's all flying about, Auntie Maureen, let's hold hands. Everything is flying about. Our world and our clients' worlds are changing very quickly, and the problems of the inner cities today will not be solved with solutions from the ivory towers of yesterday. We will, I propose, have to find the courage to let loose of certainty and adopt a much more improvisational learning stance, a stance that focuses on the questions rather than on necessarily pre-established solutions. Real growth and learning take place not by discovering the right answer, but loving and living in the questions. True dialogue between phenomenological universes is bound to take us in new and unpredictable directions. But surely if our world, our field, and our clients ever needed to go in new directions, now is the time. And surely at least one of the new directions will have to be back from isolation and separation and towards our relationships and connections. Thank you.